Thank you so much to everyone for engaging dementia for having me here today. So I'm going to talk about a project I'm involved in, which was to develop a model for palliative care for people living with dementia at home. So first, I'd like to talk a little bit about the case for dementia palliative care. So we know that dementia is a life-limiting illness, and although it depends very much on the age at which someone is diagnosed and the subtype of dementia they have, but the median survival time after a diagnosis is reported to be 4.5 years. The World Health Organization also identifies dementia as a leading cause of death worldwide, and there are no current curative treatments, thus all treatment in dementia is essentially palliative. So a palliative care approach can be appropriate at any stage of dementia, and in addition to that, the involvement of specialist palliative care services can be appropriate depending on the individual's symptoms and other care needs. In particular, with dementia, advanced care planning needs to be considered early. And I think a key point is that effective end-of-life care is made possible by a palliative approach to care being taken throughout the disease. And in a minute, I'll talk a bit more about the difference between end-of-life and palliative care. So are people with dementia getting palliative care? So despite this kind of case for dementia palliative care, we know that unfortunately people with dementia are less likely to be referred to specialist palliative care than cancer patients, despite having similar end-of-life symptom burden. And why is this? So I suppose there's some kind of unique aspects of dementia which differentiate it from other illnesses which specialist palliative care might be involved in. So one is the prognosis. We know that with dementia, there's a slow disease progression, occasional remission, and frequent comorbidities. So it can be really difficult to prognosticate in dementia. Some symptoms in particular, like obviously cognitive impairment and communication difficulties, and maybe in particular the non-cognitive symptoms of dementia might make it more difficult for those non-dementia specialists to engage with. Shared decision making, which is so important to palliative care and to end-of-life care. We know that carer stress is, that there's particularly significant emotional and practical implications for family members of people with dementia. And unfortunately, there is still some stigma around, both palliative care and dementia. So with palliative care, some people, still mistakenly think it's only for people with cancer, it's only to do with what happens within a hospice. And with dementia, even though, things have drastically improved in the last number of years, maybe there's misunderstandings amongst the general public and maybe even some small, parts of the healthcare professions that don't quite understand what dementia really is. We also have figures from England and Wales that show that the overall demand for palliative care is expected to increase by up to 42.4% in the next 20 years. And they've identified that dementia is the main driver of the increasing need of palliative care going forward. So I suppose it's quite timely and it's quite important that we look at what are the needs, the palliative care needs of people with dementia, and how can those needs be met, within dementia services, and what needs specialist palliative care involvement. So just before I go on, I'm just going to touch on some definitions. So when we talk about palliative care kind of as part of this project, we're using the definition of the active holistic care of patients with advanced progressive illnesses. And it's also care that's applicable earlier in the course of the illness in conjunction with other treatments. So when we're talking about palliative care, that's distinct from end-of-life care, which is care specifically for the last phase of life and into bereavement. So something else just to touch on, if anyone isn't aware, are the levels of palliative care. So there's 3 levels. The first is a palliative care approach, and this is something that any health and social in their day-to-day activities, and it's looking at the holistic needs of a person, their psychological, their social, spiritual and physical needs. General palliative care then is, that refers to some palliative care. So people who have some bit of extra training in palliative care. And finally, specialist palliative care is, of course, those who have specialized in palliative care as a discipline. So again, a lot of what we're talking about and what I'm going to go on to talk about when I use the word palliative care, I'm using it in a very broad sense and, not limited to just end of life care, while it does include that. Okay, so before I bring you on to the project, I'll give you a little bit of background so I suppose kind of about 10 years ago, there was some increasing interest in this concept of palliative care for non-cancer illnesses and for dementia in particular. So in 2014, the Joint Programme for Neurodegenerative Disease set out priorities for palliative and end-of-life care research. And they specifically said that consideration of effective models across Europe would be what is most needed. Then in 2016, I was involved in an interdisciplinary workshop on palliative care neurodegeneration. So there's a team of us that got funding from the Irish Research Council to host, I think they were called Creative Connections workshops. We had people with dementia, family members, advocacy, academics, clinicians into a room to discuss, what might be the priorities in palliative care and neurodegeneration. And we had really interesting talks throughout the day. And at the end of the day, we had a panel session. And in that, we kind of discussed what are the gaps? And again, a model of care is something that came up, something that was missing and something that would be really, really useful. So there's a team then that went on to develop the Model for Dementia Palliative Care Project. So the project aim was to develop a model mapping out what services and treatments a person living with dementia might need so that the health system can better organise their care. I suppose when designing the project, we had to think about what setting, and I suppose because it was, a research project and had to kind of fit in within certain remit for the funders, we had to kind of choose a particular setting. So when we looked at it in Ireland to the UK, we know about 2/3 of people with dementia live in the community. And for most, this is also where they want to live and be cared for. So we decided to, build this first model around community dwelling people with dementia. But, and that future models might kind of look at other settings like long-term care. Something else we're very cognizant of was to make sure that the model was going to complement the National Dementia Office's overall model for dementia care. So the project took place over about 4.5 years. The research board, the principal investigator is Professor Suzanne Timmins, and then there's a number of co-investigators, including myself, and also an expert advisory board, which included the National Dementia Office, people with dementia and family members, and basically a range of health and social care professionals from across Ireland and the UK. Okay, so you'd be happy to know presenting on a project that is nearly finished. So we do have a model now that is in its, we're kind of going through the very, very final refinements of it at the moment. But this was built on, a number of research studies. So I'm just going to bring you through each of those very briefly, and then I'll kind of provide an overview of the model of dementia palliative care. So the studies we undertook were a scoping review of the literature, a survey of experts regarding key model components. We also went to some sites that were providing dementia palliative care to do evaluations, and we undertook a consultation process with key stakeholders. So the first piece I'm going to report on is the scoping review. And so the first thing we did was we looked to the literature to see, what is the evidence for dementia palliative care for people at home in the community. And we were also interested in looking at what was the evidence for cost effectiveness. Now, most of these studies have been published, so I'm just giving a very brief overview today, but if anyone is interested in kind of the nitty-gritty detail, you can use these references to look up the full papers. So we found just 18 studies which were, met our criteria dementia palliative care at home. And just overall, I suppose, to comment on what were the key findings. So most studies were limited to people with advanced dementia or requiring end-of-life care. So there still wasn't a lot done at that time for, palliative care for people in earlier stages. Most of the included studies were of low to moderate quality. But we did find some evidence for different care models, and we could group these into 3 types. So the first type of dementia palliative care services were basically existing dementia services that provided some level of enhanced care, either through, extra training in palliative care or kind of collaboration with a particular service. Conversely, then we had some specialist palliative care services that kind of upskilled in dementia care. And there's also 3 papers that reported on integrated services where a full dementia service and kind of a full specialist palliative care service came together to provide care to people in their homes. So again, the studies were all quite small, so it's very hard to, to conclude were they very effective or not. But from any evidence they collected from families, the feedback was fantastic. The people really appreciated this kind of really intensive care at home. And unfortunately, there is no full economic evaluations assessing cost effectiveness, but some studies did kind of report that, some data that kind of suggested that dementia palliative care would actually be cost saving. So considering that there wasn't a whole lot published in the literature, we also conducted a survey of experts. So the aim of the survey was to explore key stakeholders' views on what a good model of palliative care in the community for people with dementia might look like. So, we're very aware that just because something hadn't been studied and made it into a journal publication doesn't mean there mightn't be something there that was important to consider. So we actually identified a really purposive sample of expert clinicians who were practicing or researching or making policy in the area of dementia palliative care. And we looked for people across Ireland, Northern Ireland, England, Wales, and Scotland. So we had 112 kind of expert responses received. And again, this is being published if anybody wants the detail of it. So what these people felt were the most important components of a model of dementia palliative care at home. They were information, education, and training, support for the carer, access, comprehensive and continuous support, integration of services, advanced care planning, and end-of-life care. Now, we were also kind of looking down the road to the potential implementation of the model, and we asked the experts what they felt might be potential barriers to a model of dementia palliative care. So the first barriers were around service organisation. So, people spoke about the duplication or fragmentation of existing services in Ireland. A lack of resources, unsurprisingly, came up within dementia services, within specialist palliative care services, and kind of within health services generally. So then others felt that maybe just dementia palliative care wouldn't be seen as a priority, and it might be difficult then to get the funding, to meet that lack of resources. Other barriers were around understanding. So a lot of people felt that there's some misconceptions around both dementia and about palliative care. And other barriers were relating to the provision of it. So disease-specific barriers. How does somebody with no diagnosis of dementia, get good dementia palliative care? And again, the difficulties in predicting end of life and a lack of advanced care planning would impede good end of life care within a palliative care model. Okay, so then the last kind of piece of research we undertook were site evaluations. So we had a good idea at this stage of what might the key model components, might kind of theoretically be, but we also wanted to see, how might a dementia palliative care service really run in practice. So as part of that the survey I mentioned of experts, as part of that, we asked people to identify any services they were aware of that were providing dementia palliative care to people living at home, and were particularly, good examples. So there is a long list of almost 50 services providing dementia palliative care across Ireland, the UK, Scotland and Wales, and Northern Ireland. And of those 50, we kind of narrowed it down to the 5 we felt were the best exemplar services. We described each of the services in detail, and then we also compared across them to see what was the common learning across these 5 services. And they were all really, really different. So it was interesting to see, how each of them functioned really differently, but were able to provide really good quality care for people with dementia. So just as an overview, so the 5 services we evaluated, as I said, all looked very different. Now, we did look at one intellectual disability service, which I won't go into in detail here today because that's nearly for another talk. So of the other 4, there were 2 that were specialist palliative care led services. So these were basically, run out of hospices, and each of them had kind of a dementia nurse and some people with upskilling in dementia on the teams, so that they were almost looking for, anyone with dementia in their areas that had palliative care needs, and were very open to including them in their services. The other 2 examples then were, we'll say, dementia service led. So one was led by a psychiatry of old age service in England. This one was for people with just advanced dementia, so people who were in their last year of life with dementia, and it was all around kind of a key worker model. And this key worker putting all supports and equipment and district nurses and everything in place to keep that person living at home until death. And the other then was a very different model. It was kind of a primary care led model, and it was kind of around a key worker, but linking them in really early on, quite soon after the person's diagnosis, and ensuring that they were linked with all of the relevant supports, that when advanced disease and end of life came, that advanced care planning was done, and that the different supports were in place to facilitate that care at home. So they were the 5 services. So based on all of that, we developed a draft model. We then undertook a multi-phase consultation process to refine this. We spoke to almost 100 people, including healthcare professionals, academics, people with dementia, and carers, through a variety of methods. And with this, we refined multiple versions of the model. So as I said, we're pretty much at the final version now, just making kind of the final tweaks. So this is what it looks like. Now, the model itself goes into an awful lot of detail. So what I'm really going to focus on just for the last few minutes of the talk are the key components of the model. This is really the meat of it, what has to happen as a palliative care model. So there were 6 key components, and I'll just go through each one now briefly. So the first component of our model is around comprehensive care that covers all dementia needs from diagnosis onwards. So in the model, we define each component, and then we give some examples of what that should look like in a service. So some kind of goals that should be met. So we have, for comprehensive care, there should be regular discussion and agreement about current and future goals of care with the person with dementia and their carer or supporter. There should be a regular needs assessment conducted by a member of the MDT, considering physical, psychological, social, and spiritual needs. That there should be use of best available tools to assess individual symptoms. And there should be availability of a range of non-pharmacological and pharmacological treatments to address symptoms, and that'll depend on local resources. So component 2 then is around person-centered practice and care that tailors the person's care to their interests, abilities, history, and personality. So what might that look like in a service? Well, the emphasis should be on supporting the person in what they can still do, not in doing for them. Home support must be provided as an intrinsic part of a dementia palliative care service at home. And home support should be able to, 1, should be care to support a person to continue to live a meaningful life. So home support for companionship or support with meaningful or enjoyable activities, as well as care at home for practical care needs. It has to be responsive and flexible and continue into end-of-life care if required. And conversations around prognosis and advanced care planning should occur at the earliest appropriate opportunity, facilitated by a core member of the MDT in a suitable location, and that is revisited and documented regularly. Component 3 then was all around integrated care that links people with services that work seamlessly together. So what that might look like, the MDT would usually be led by a dementia service, such as a memory assessment and support service, with ongoing input from specialist palliative care community services, such as through a community liaison, specialist palliative care nurse on the dementia MDT, or phone or virtual team support from the SPC team, and prompt access to specialist support if required, with a clear pathway to the service. For people with dementia who are not under a memory service, their GP should be able to refer them directly to palliative care services. And all people with dementia families should have a single name point of contact to the core service providing their dementia palliative care, and they should have access across settings, including the person's own home. So then component 4 is accessible care that ensures a basic level of support to everyone, regardless of their location, time, illness, or ability. So the overarching dementia model of care specifies services for community hubs. So this is kind of based around that. Home care hours, again, need to be available to all people living with dementia in the community, and that they must be very flexible. The Dementia Palliative Care Service should provide urgent review, such as via a day hospital type service, to address symptoms that might avoid a trip to acute hospital or A&E. And, you know, again, this is really important in kind of a home care model. And for people undergoing a period of acute illness at home, phone support from relevant consultant or ANP should be available 24/7. The next component is all around care for the carer, which again is obviously really critical if if the person with dementia wants to stay living in the community. So what that might look like: the main carer is defined, even if not directly providing care anymore. The primary service should inquire about the carer's own needs regularly. Effective, acceptable respite options in and out of the home should be easily accessible. And the carers should receive comprehensive bereavement support from members of the MD before and after death. A comfortable environment at death is provided in the person's preferred place of care where possible. And for home death, there should be close working with the community MDT. And night nursing services, which definitely need to be further resourced currently, need to be available for people in the final days of life. So I suppose that was kind of a whistle-stop tour of the model, but the hope is if those components are implemented, that the longer-term outcomes will include people with dementia being treated with respect, improved well-being of people with dementia and their families, improved patient experiences, improved death and bereavement experience. So what's next? So we have, as I said, a very near final version of the model now. And we designed it to be complementary to the National Dementia Office's model of care. We did work with the National Dementia Office throughout. So, luckily, the core principles of the model of care for dementia really overlap with the core principles, I think, of the dementia palliative care model. So I think a lot of good dementia palliative care really is just good dementia care. And the holistic the way we talk about holistic care and palliative care is very similar to person-centered care and dementia care. So I think a lot of that early good palliative care will be hopefully covered in the model by good general dementia care. So I suppose the implementation phase then we'll have to look at, so what aspects of dementia palliative care are covered in the current model, and what aspects, maybe those around end of life care will need to be augmented. And again, so this current model focuses very much on people living at home, but hopefully future work will look at long-term care and other settings. Just to conclude, I suppose the hope of a project like this and the model is that every person living with dementia in Ireland will receive the best possible care, and that includes the appropriate level of palliative care. And those are my references for anyone interested.